All right, good morning, everybody. Good to see such a full room today. Just check the connection on the video. Dr. Wilensky, can you hear us on your end?
I can hear you just fine, thank you.
Wonderful, with a ton of time to spare too, that's great. Good morning and welcome to today's Evidence-Based Health Policy Project briefing titled The Affordable Care Act and Medicaid, What Comes Next and How the State Might Prepare. I'm Sam Austin, the EBHPP Project Director. Thanks again to everyone joining us here in the Capitol and online today. Have an extremely full house, as you can tell, which is an indication of the interest in this topic. We did look into reserving a larger space here at the Capitol for today's briefing, but they don't have video conferencing in the rotunda. The kind of chilly for the Capitol lawn, so here we are. Appreciate your patience and your flexibility. Before we get started, I'd like to briefly introduce the Evidence-Based Health Policy Project. The broad goal of this program is to connect research and expertise and information, both at the university and elsewhere, into the health policymaking process here at the state capitol. This goal is driven by the idea that ongoing dialogue and development of trust between policymakers and academic researchers can enhance and elevate the work of both. We work to serve as a resource at the Capitol and a resource on campus through the convening of nonpartisan, high-quality, and timely events such as this one, and facilitating interaction and mutual learning in many different forms between the legislature and the university. This project is a unique and formal partnership of the University of Wisconsin-Madison Population Health Institute, where I'm housed, the La Follette School of Public Affairs at UW-Madison, and the Wisconsin Legislative Council. I'd like to recognize Hillary Shager from the La Follette School, who is in attendance today, as well as Steve McCarthy from Legislative Council. They're our project partners, and they play an integral role in making our project successful. This project is made possible by the generous support of our funders, which include the Wisconsin Partnership Program at the UW School of Medicine and Public Health, the Community Academic Partnerships Corps at the UW Institute for Clinical and Translational Research, also known as ICTR-CAP, and from the UW-Madison Chancellor's Office. We thank them for enabling us to convene venues such as this one and for supporting our work to connect research into the policymaking process. We develop these events with input from our Legislative Advisory Board, which is a bipartisan group of legislators representing a range of perspectives on health issues. Our current board membership includes Representative Joe Sanfelippo, who's our moderator today, Representatives Deb Kolste, Daniel Reamer, Jesse Rodriguez, Joan Ballweg, and Paul Tittle, as well as Senators Devin Lemieux, Mark Miller, and Leah Vukmir. We truly appreciate their engagement and their involvement in this project. As you can see, we have video coverage of this event, both through Wisconsin Eye and through the Instructional Communication System at UW Extension, who is conducting our webinar for us today. For those of you joining on the ICS webcast, you'll see you're able to enter questions for our panel. I'll do my best to work some of those questions submitted online into our Q&A session, both for Dr. Wilensky and for the panel as a whole at the end of the program. And whether you're joining remotely or here in the room, I hope that the Twitter inclined among you will add to the conversation using the hashtag EBHPP. For those of you in attendance today, your folders you received upon entering had several documents, today's agenda, biographies of each of our speakers, and a list of further resources to dive deeper into this topic. There are also two handouts giving an overview of the EBHPP and the UW Population Health Institute. And finally, you'll see a pink evaluation sheet that we hope you'll take a minute to fill out and leave either with staff at the doors on your way out or drop on the table on your way out the door. We aim to be as responsive as possible to your audience needs and the interests of our attendees, and we can't do that without your feedback. To briefly set the table before we begin today, again, today's high attendance is indication of the appetite and need for information on this topic here at the state level about potential federal action regarding the Affordable Care Act and Medicaid under the Trump administration and the incoming Congress. These federal decisions and how the state reacts to these decisions will have dramatic implications for access to health care coverage and the provision of health care here in the state and nationally. The most direct impact will likely come for the over 200,000 Wisconsinites who purchase coverage through the ACA exchange, as well as the over 1 million people who are covered under Wisconsin's Medicaid program. But the implications of these decisions will also affect people with pre-existing conditions, employees at firms that may shift to high deductible health plans, senior citizens enrolled in Medicare, in short, basically everybody. And while we don't claim to have any crystal balls here in the room today, I believe today's panel, which combines perspectives on federal action from Dr. Gail Wolinsky, information on state Medicaid policy from Medicaid Director Michael Heifetz, information on health savings accounts and high deductible plans from Professor Justin Sydnor, and issues for consideration for consumers and insurance markets as we move from a repeal to replace world from Donna Friedsam. These perspectives will provide lawmakers and the public with a solid framework for thinking about these issues and considering next policy steps. With that, I'll hand over to today's moderator, Representative Joe Sanfelippo. Representative Sanfelippo was first elected to the State Assembly from the 15th District in 2012 after serving on the Milwaukee Board of Supervisors. He's currently the chair of the Assembly Health Committee, serves on the Assembly Committees on Mental Health, Transportation, and Financial Institutions, and is a member of the Governor's Council on Highway Safety. He also participates tomorrow, along with several other panelists, in a Wisconsin Health News briefing that deals with these same issues of the future of the ACA under the Trump administration. So again, thank you, Representative Sanfelippo. Thank you to our panel. Thank you to the audience, and take it away.
Thank you very much, Sam, and thanks to the Evidence-Based Health Policy Project for putting on this discussion. And I think just the sheer magnitude of the amount of people here for this topic, as you indicated, speaks to the relevance of the issue. And I think kind of the uncertainty as to going forward, what we're going to be able to do and what we can do and how we're going to proceed. So it's a great topic, and having an overflow room is a good problem to have. So with that, we'll get started with our first speaker. Dr. Gail Wolinsky is our first speaker today. She's joining us by video from the Bethesda, Maryland. Dr. Wilensky is an economist and senior fellow at Project Hope, an international health foundation. She directed the Medicare and Medicaid programs and served in the White House as a senior advisor on health welfare issues to President George H.W. Bush. She was also the first chair of the Medicare Payment Advisory Commission. Dr. Wilensky, thank you very much for taking the time to be with us today.
My pleasure. I am appreciative of technology so that I can join you by video conferencing. I spent 27 years living in Michigan, and my agreement was as much as I enjoy being in Madison in January, it can leave a little to be desired. And I gather with some of the weather challenges you're having now, that was a good decision. So thank you for letting me start this morning's program. I'm going to share with you my views about what happens next with regard to healthcare reform, what I have dubbed reforming healthcare reform. I'm going to spend a little time reviewing with you the major features of the Affordable Care Act as we now know it, and then tell you, particularly with regard to Medicaid, some of the issues that I think you need to think about going forward. My thoughts, of course, can be expanded upon, maybe challenged by your very able Medicaid director, who clearly knows much more about your program than I do, but I've been trying to inform myself so I understand what Wisconsin has done thus far in the direction you appear to be heading. When we look at the Affordable Care Act, it has sometimes been described as comprehensive health care reform, but actually that's never been a good description. It was primarily about expanding coverage and reforming insurance, particularly as it relates to the individual market. Those aren't trivial issues, but actually, as it turns out, those are the easier issues to resolve in health care. There has only been limited delivery system reforms, mainly involving value-based purchasing, some of the bundling payment, and other pilot projects, and the promotion of accountable care organizations which attempt to have hospitals and physicians which haven't previously worked together have an ability to share in savings by coming together and working in a more coordinated way. Again, Wisconsin has some of the outstanding systems already that have been around for a long time, such as Marshfield Clinic and others. This is an attempt to try to broaden that type of delivery system. There is also a Medicare Innovation Center, which has been responsible for promoting many of the pilot projects, although to date, the results that they have found with the various demonstrations has been at best mixed in terms of finding successful ones. We usually have talked about how the accountable care organizations and the Affordable Care Act affects individuals or the deliverers of care, hospitals, and physicians. Excuse me, please. But employers are also affected. It was basically a pay-or-play system. That is, if employers didn't provide what was regarded as affordable coverage, they had to pay a penalty, and that was either they didn't provide coverage at all, or it cost the individual employees too much money. There were also some new standards that were put in place. Employers who didn't have plans that met those requirements could be grandfathered, but only if they didn't change their plan in any way. As most people have heard, the system relied on subsidies and insurance exchanges as well as an expansion of Medicaid. The exchanges were initially to be set up as state-run, as most people have heard. In fact, almost all states have used a federal exchange, and that's where you go to get an offering of qualified plans. Small employers, initially under 50, and then an opportunity for those under 100 employees could also participate in the exchanges. In a place like the District of Columbia where I live, the small employers were forced to have their employees go get insurance in the exchange, whether or not that's what their employees wanted. Starting in 2017, there's an ability for the exchanges to be opened up to large employers because of the uncertainty about the future of the Affordable Care Act. I don't know where that provision lies now. Individuals who did not qualify for Medicaid, which had an expansion, I'll get to that in a minute, and who did not have employer-sponsored insurance offered to them, were eligible to receive subsidized insurance in the exchange, and the subsidies were on a sliding scale basis up to people with 4 times the poverty line, which for a family of 4 in 2016 was $97,000. In 2014, when this started, that number was $88,000, just to give you some sense about what kind of families we're talking about. The actual Affordable Care Act changes, in large part, did not start until January of 2014. As you'll recall, the actual legislation was enacted in March of 2010. In those first couple of years, there were some insurance reforms that went into place, like allowing adult-dependent children up to the age of 26 to stay on their parents' plan. I sometimes comment that only in America do we regard 25-year-olds as still kids. That had some ramifications that I'll talk about in a minute. But most of the major changes in terms of the expansion in Medicaid for those states that were partaking in that and in the subsidized insurance did not begin until January of 2014. So in January 2014, the negotiated insurance plans became available, and as I have mentioned, the Medicaid program for states that wanted to participate was expanded up into anyone who was under 138% of the poverty line. Previously, as most of you know, states had a lot of authority to determine who among their low-income populations should be eligible. Children and pregnant women had priority enrollment and many provisions that required their coverage, but particularly childless couples and individuals or those with substantial assets, even if they had low income, were frequently not covered. 31 states decided they would participate, even though for the initial 3 years it was 100% federally funded, it was in the law that would slide down to 90% federally funded for the expansion starting in 2017. That's basically where we are now. Wisconsin, among 19 states, chose not to participate. They, however, made a decision that had important ramifications for the citizens of your state, and that is they covered everyone up to the poverty line. The reason that was important is the legislation had a peculiar feature in it that had more consequences than was understood when it was passed, given the Supreme Court decision that states could not be forced to expand their Medicaid program. That happened in 2012. And the important ramification was that the subsidies for private insurance available in the exchange were only for people who had at least income at the poverty line. So by expanding the program of Medicaid to include all of those below the poverty line, Wisconsin guaranteed that those who were at and above the poverty line would be able to receive subsidies and to buy their insurance, subsidized insurance, in the exchange. So it had not only a general important ramification of sweeping in everybody below the poverty line, but making sure that those who were in that in-between stage of the poverty line and 138% of the poverty line be able to receive the maximum subsidy to purchase private insurance in the exchange. The insurance mandates, which initially were very low penalties, started to take effect in 2014, although whether or not you were eligible for the mandate and whether or not you were eligible to pay a penalty had a lot of clauses and provisions attached to it. Now, the upshot of having passed this legislation is that there has been some clear progress in at least one traditional problem area, and that is too many uninsured people in the United States. I'm going to talk in a minute about the as yet unclear impact on spending growth that the Affordable Care Act had. It was clear that, and has been clear from the studies that have been done since its passage, that not much has happened with regard to patient safety, medical errors, or clinical appropriateness, although that continues to be a problem area for the United States. When we look at estimates of the uninsured, this is the clearest win for the Affordable Care Act. Hardly surprising, we are in the process of spending over $1 trillion, but indeed we have seen a substantial reduction in the number of uninsured, going from about 16/17% in the depths of our recession in 2010. It had been running close to 16% even before that, to a little over 9% in 2015. So a very substantial reduction in the number of uninsured. That number appears to have plateaued, at least for now. 2016 remained very flat. There's a little delay in getting the numbers, so we're not exactly up to speed, but it looks as though that number has now flattened out. What is important to understand going forward, particularly as we are now in a potentially new period with regard to health care reform post the Affordable Care Act, is that the majority of people who became uninsured, having been uninsured, received that change in status as a result of the expansion in Medicaid, which was not what had been expected. And frankly, most people probably don't know, given so much of the attention has gone to what is going on in the exchanges that contains the subsidized private insurance, But the large expansion happened as a result of Medicaid. It has had, of course, repercussions already in terms of the number of people covered. I've indicated the large increase in the number of people nationally covered versus initial estimates on the slide. The spending, of course, has also been much higher. This is now about to become a major issue for some of the states because they will be responsible for 5% of the spending of their extended Medicaid population as of this year, and depending, of course, on what happens to law, that will go up to 10%. It was also clear from estimates that even with the Affordable Care Act passage, that there would be a substantial number of people left uninsured in the United States 10 years out. So the Congressional Budget Office estimates of what the uninsured would be in 2025, 2024, 2026, it pretty much stayed flat for the last several years, was that there would be 28 million uninsured. This is again going to be important going forward. There is a lot of interest among people, myself included, that we not lose the 20 million people who are newly covered as a result of the Affordable Care Act law when we make changes, and also reminding people that this is not the end of our issues with regard to what happens with the uninsured. Now, the healthcare spending is a little harder to determine how much of what we observed had much, maybe anything to do with the Affordable Care Act, and how much had to do with other changes. We know, people have reported, that healthcare spending from 2010 to 2013 was very slow in the United States, historically slow growth, in fact, growing in several of these years less than 4% per year. However, there have been debates all along as to how much of it was induced by policy changes in the Affordable Care Act, how much of it had to do with changing coverage, either as a part of the Affordable Care Act or, more importantly, because many more people were involved, the use of high deductible plans by many employers, and how much of it was related to the recession. Us policy analysts were having many debates in print and in speech about this. I, just as a matter of sharing with you my going-in position, believe that the majority of the change had to do with the recession, and the second largest cause had to do with the increased use of high deductible plans, both in the exchange, although that was only for the most of that time 8 to 10 million people, not very many compared to 160 in the employer-related market. And then at a third level, might have been reflecting changes in payments strategies that were either a part of the Affordable Care Act or what was going on in the private sector. A report was issued by the OECD in August or September of 2015 that provides very useful data to assess this issue. What they reported is that as large as the decline in spending was between 2009 and 2014 relative to 2001 to 2009 in the United States, and as I've indicated, we had several years of historically low spending growth, our decline was actually less than the OECD average of 32 countries. And what this suggests more clearly than anything we had previously had available is that most of the slowdown that we enjoyed in the United States from 2009 to 2014 was related to the global recession. And we can say that now with more confidence because of what we see happening in 31 other countries. It was clearly not the Affordable Care Act affecting these other countries. It was much more the global recession. It has helped us, particularly in terms of slow Medicare growth, which also occurred. And we ought to enjoy the fact that it's bought us a little breathing room. But we need to be aware that now that we are in a recovery stage, thank goodness, we should expect to see higher healthcare spending growth, and indeed we are already seeing that. 2015 and 2016 had spending growth overall in the United States at a rate of about 5.8% per year. We are seeing increased spending in Medicare, both because the baby boomers continue to be aging, which started in January of 2011 and will continue until 2030, but the per capita spending in Medicare is also growing up. So it looked like we were having a temporary breather as one of the few good parts of what was a very unfortunate and prolonged global recession, and that some of our spending challenges may be returning. We'll have an opportunity to see whether we've learned anything about how to slow down spending in the interim. Now, it's been a big surprise for most economists that we have healthcare spending challenges in the United States. There are many factors that drive for higher spending. I just listed a few of the ones that I think are most important, but you could easily come up with a list double the size. As an economist, I worry about the differential favoring of employer-sponsored insurance relative to individually purchased insurance. That is, if you have employer-sponsored insurance, the part that is paid for by your employer is not part of the employee's taxable income, not the employer either, but it would be an expense no matter what. This is not a small item. It's about $260 billion of revenue loss to the Treasury. There is also a lot of insurance involved, third-party payment. That's good because healthcare is very expensive, but it also has an impact on increasing spending, particularly for us as a country, because unlike many European or other countries around the world, we do not directly control in a global way spending or use or technology except in very limited ways. And while we have talked a lot about value-based reimbursement, most physicians continue to be reimbursed in the U.S. Through fee-for-service, which has some positive aspects, but encourages and rewards the provision of more services and therefore can be a driver in spending. And there is a lot of concern, I'm one of those, that because we have not resolved our legal liability issues in the United States, that these are drivers of spending because of the vulnerability that physicians and hospitals and manufacturers feel that they have because of the continuing liability that they face. As everyone knows, the election, contrary to many pollsters and media predictions, was not what was expected. President-elect Trump won the presidency with a number of 30-plus more electoral votes to spare. 304 was the final count. Mrs. Clinton won the popular vote by a couple million. Basically, this is driven almost entirely by California. A reminder about why the Founding Fathers, to keep all 13 states in, did a blend of popular vote and the Electoral College reflecting the number of states that are there. But more surprising in many ways, even than the Trump win, was the fact that Republicans retained control of the Senate. This is surprising because there were 24 Republican seats that were up for election versus 10 Democratic seats. Whenever you see that kind of imbalance, there is a presumption that you could see a switch in power. But to many people's surprise, myself included, I had predicted about the same number, but I had thought, given the 24-10 challenge, that Democrats would probably be 51-49 or 52-48, but I was wrong. Republicans only lost 2 seats and maintain a majority of 52-48. Also, Republicans lost a surprisingly few number of seats in the House. Again, if you think back before the election, there were a few that were saying there could even be a change in control. That was not a common assumption, but many people thought 10 to 15 seats was not an unlikely outcome. And in fact, Republicans only lost 4 seats, so the count was is now 239 to 193. Now, this election has some very important ramifications for what happens next with regard to health care reform. We hear frequently reference to the fact that Republicans have the White House, the Senate, and the House, and therefore they can have their way with regard to health care, but the response ought to be not so fast. Republicans are in control for the White House and both houses in Congress, but at least as importantly, Republicans do not have a filibuster-proof majority in the Senate. As you may recall, the first 2 years, or about the first year and a half actually, of President Obama's election period, the Democrats had a supermajority in the Senate. That is, they had 60 votes of Democrats if they all held together, and that was true until about September, I think, of 2009, when Senator Kennedy lost his life. This means that Republicans can only pass legislation with regard to a simple majority if those issues are related directly to budget, and they use something called the budget reconciliation procedure. Otherwise, they will need 8 Democrats, assuming they can keep all of their members in line, not such an easy requirement frequently, in order to be able to have at least 60 votes. I am sure many in the Republican leadership wish that weren't the case. It is more challenging when that happens. But actually, I'm one of the people who think that this will keep the party from overreaching, because when both sides know that they don't really need the opposition in order to be a part, that can lead to bad behavior on both sides. That's not an issue now. In order to get legislation passed that reforms how insurance is provided, all the things not directly related to funding, Republicans will need buy-in from Democrats in the Senate. There's very little doubt, however much you may regard excuse me, the Affordable Care Act that it needs to have some change. And I say that because of the churn that continues to exist in the exchanges and the substantial dropout by large, well-established insurers that occurred in 2016. This is not the sign of a healthy market. As it exists now, there has been, on average, an increase of 25% in premiums for the 2017 enrollment period that is still ongoing. It has happened in the past because of a number of policies that encouraged the kind of churn that we saw, including many of the special enrollment attempts, and also because of some of the rigidity in waiver rules. The question really is going to be what happens next, and I want to talk a little bit about that. There are a number of what I would call, as a health policy person, policy-related mistakes, all of which are understandable at a certain level, but which contributed and which could have been predicted to contribute to the kind of churn that we have seen. Just going to quickly mention some of these. One has to do with the allowance of premium variation of only 3 to 1, although the actuarially fair estimate was that premiums for the lowest young adults to the pre-Medicare population should have been allowed to vary by 5 to 1 on an actuarial basis. What that translates into is that some of the young adults, especially the young adult males, were going to be asked to pay more than what the actuarially fair value of their premium would be. It was done to try to soften the blow for the pre-Medicare population. But what it meant is the group that we affectionately refer to as the invincibles were going to be asked to pay more than what would be regarded as an independently fair price for a premium. And given their clear reluctance to buy already, that just upped the bar. Similarly, it was one thing to allow 26-year-olds to stay on their parents' policy until insurance could be available to them on a non-discriminatory basis. But allowing this to continue after January of 2014, which was understandable at a political level because it was very popular, meant that there was another group of healthy young adults who wouldn't be joining the risk pools in the exchanges, again exacerbating the risk problem in the exchanges. And of course, the ACA by law guaranteed that no matter how sick you might be, 3, 5, 6 years down the line, if you had waited to buy insurance, you would be subject to some penalty, not much if you were low income, a little more if you were not low income, but you could never be charged more because you had waited however long you had waited to buy insurance, again, exacerbating the risk problems that the exchanges face. There was also the problem that risk corridors that was trying to prevent losses for insurance companies participating in these early years, which is not such an unreasonable idea, had not explicit funds made available, not appropriated, were in this strange interim period. Now the courts have ruled in favor of the House Republican position that these were not appropriated funds, and now we'll have to figure out what happens next. There were also some very lenient special enrollment rules put in place to try to encourage as many people as humanly possible to enroll, which again is understandable at one level, but exacerbated the risk problems that were going on and the churn because most of the people who enrolled in these special enrollment periods had unusually high use, but they also dropped out frequently after enrolling late, staying a month or two, using the healthcare system, and then dropping out. So they were basically causing problems on the way in and the way out, so to speak. So those all exacerbated the risk problems. And then, of course, there was the, I don't know whether we would call it PR problem, but certainly an area that caused a lot of anger for many people was the promise that had been made that if you like your insurance, you can keep your insurance, and if you like your doctor, you can keep your doctor. It's an issue I've been questioned about many times, and the fact is, at the moment that comment was made, any of us who understood the healthcare marketplace realized that was a promise no administration could make because it depended on whether or not your plan met the new requirements and whether your physician chose to enroll in a particular plan or not. And to make a promise like that, at the same time you required plans to either provide coverage as required or not continue, meant that you couldn't possibly keep that promise. What do we do now? Well, we are all waiting here in Washington and elsewhere to see. It would be possible, actually, to reform the Affordable Care Act, revise it substantially and reform it. Whether technically it would be possible is not as relevant as the political needs, however, to repeal the Affordable Care Act and then replace it. It seems quite clear, both on what we've seen from past legislation and what people are saying, that it would be repeal with a delay in the actual implementation and a replacement plan. And one of the big debates is whether or not you will pass both pieces of legislation together, which I would strongly favor, or whether you will do them sequentially, which has seemed more likely, assuming there are 52 Republicans in the Senate, that would agree to the repeal legislation with a delay in implementation, followed by replacement legislation. If 3 Republicans don't support that strategy, and at least 1 or 2 have indicated some question already, and 1 or 2 others potentially some question, then they could force them to be done together. The real question, of course, is what will that replacement look like? The clearest example that we have is the bill, A Better Way, that was passed by the House with major leadership efforts by Congressman Ryan in terms of what that might look like. And basically, what that says is rather than have the exchange subsidies we now see, you would have a refundable tax credit, and there would be a limitation placed on the unlimited tax exclusions for employer-sponsored insurance, that the premiums could vary by 5 to 1, the actuarially fair amount of variation. That rather than saying there could never be any distinction made in pricing for those with pre-existing conditions, there would be basically the HIPAA rule that is now present for those of us with coverage in groups as small as 2 or as large as many thousand. And that is, if you are continuously covered, you maintain continuous coverage, you are protected against pre-existing conditions. And that for those who don't maintain continuous coverage, they would be able to go into a funded high-risk pool. I've thrown in this as my own strategy that I wish had been used previously, which is to do for the under 65 what Medicare already does for its population, which is you get a year when you turn 65 or you lose your employer-related group coverage to buy into Part B of Medicare, the physician part, or Part D as in dog of Medicare, the outpatient prescription drug. And if you don't, that's your option. But if you decide at a later point you want that, you'll pay a penalty for as many months after the first year as it takes until you decide to change your mind. That might be too harsh because this is for as long as you live, but something like that, a penalty relating to how long you wait, in order to have individuals cover the cost they impose on the rest of the population because of their adverse selection. So now, what happens to Medicaid? This is as yet unclear, again, because we haven't seen the details. One of the questions is if the Republicans feel the funding that has been used for the Medicaid expansion, you'll recall I said majority, about 2/3 of the expanded covered population, we believe, came from Medicaid. Can these funds be set aside in some way for alternative use or not? And what happens to the millions of people who are now covered as a result of the expanded Medicaid coverage? Again, one of the upsides for Wisconsin is you don't have to deal with that because you didn't take that move. And the second big question is whether the Republican Congress will convert Medicaid to a block grant, which is something Republicans have talked about for at least the last 2 decades. To me, one of the big questions is the 31 states that have Republican governors, where do they stand? Where do the governors stand, and where do the legislatures stand? I find it impossible to believe that a Republican Congress would convert Medicaid to a block grant program, as much as many may be inclined to, if there was strong Republican opposition from the governors and the state legislatures to do this. So it will become very important for states like Wisconsin and other Republican states to indicate where it is they stand on this issue. Now, the big trade-off when it comes to a block grant is that in exchange for increased risk, there is the maximum amount of flexibility provided to states. That doesn't mean there might not be any provisions put in place. The Hyde Amendment, for example, is likely to be extended if there was a block grant. Restricting coverage, I would guess, to citizens and legal residents might be a requirement, but we don't know exactly what kind of requirements, but basically very few. What I want to be sure you understand is that when you talk about block grants, you really need to distinguish whether you're talking about per capita block grants or just block grants, which is a block amount of money that would be indexed forward but no other adjustments. My personal view is that it would be very risky for any state to agree to a block grant as opposed to a per capita block grant. And the reason is that, as you in the state legislature and in the agencies know better even than I do, although I did work for a state for a couple of years, the states are highly at risk on a number of areas in the event of an economic downturn. And Medicaid, of course, is one of those programs that is very vulnerable to change whenever there's an economic downturn. If you have a per capita block grant, it will automatically adjust for differences in the number of individuals who would be eligible at the poverty line or whatever cutoff you use, in a way that does not happen if you just have a flat block grant. So to my mind, a per capita block grant is a program I could argue in favor of. I'd personally like to see 4 or 5 outcome measures, metrics be required, so we have some idea what happens to the population affected. But I would be very wary about just a full block grant. But there are a lot of technical issues. What will the baseline amount be? Is it the old amount that used to be spent on Medicaid or the expanded amount? And if the expanded amount, what do we do about all of the differences on a per capita basis that exist? Do we just average them out, which means there'll be a lot of winners and losers, or what? And of course, importantly, how will the grants be indexed or increased over time? So if we are to go that way, there will be a lot of details to work out. You, of course, need to be sure that you are having your technical people and your political technical people working closely to try and get your input into any of these issues. I know your state Medicaid director will be speaking, I'm sure. I'm not telling him anything he doesn't know. The rest of you need to know that as well. I just want to close with a somewhat unrelated thought to what I've been speaking on, but it's one I feel passionately about. Wisconsin has been known as a very progressive state in terms of health care and welfare for many years. And I want to remind all of you that if what you want to do is to improve health, it's really much more important to think about what you're doing with regard to the social determinants of health, those determinants that are not directly related to medical access. Medical access is important at various points in time for adults and children, but it is really these other aspects that will determine the health of the citizens of Wisconsin. We need to focus more on prevention. We especially need to recognize that obesity has now become the new public health menace, that smoking had been 20 or 30 years ago, although some young adults are continuing to pick up smoking. And it will require a very sustained campaign for success, harder than smoking, but even more important. As important as efficient and effective health care delivery is, and of course it is important, we spend a ton of money there, it's these social determinants that really determine health outcomes then. That has to do with early childhood education, poverty, food security, economic opportunities. I was very pleased to read about your Forward Health program. That's an important start. My plea to you is you clearly understand the importance of these issues. Make sure you focus even more going forward on the social determinants as you try to decide what to do with your healthcare financing and delivery system. Thank you very much for your time, and I'd be glad to answer any questions that you have.
Very good. Thank you, Dr. Wilensky. We appreciate that. If anybody has any questions for Dr. Wilensky, we're going to ask them now, and then we'll proceed with the panel, and we'll ask questions of the rest of the panel at the end of the event. There's microphones at each door, so if you do have a question, please just make your way to one of the doors here, and then we can get, we'll all be able to hear your question. And I think you have a venue for online questions as well, too, so anybody who's out in the audience listening can ask some questions. To get started, Doctor, you know, we're 7 years down the road from when the Affordable Care Act was first passed, and we're still kicking in or phasing in aspects of that law. So how comfortable can we as states feel that the federal government is going to be able to make changes now, even if it's a repeal and replace, or repeal and make it effective at a later date, that when that later date comes, we're actually going to have a program that's ready in place because, you know, what nobody wants to see is a gap in access to coverage. And one of the things that's been great about what we've done here in Wisconsin is that Wisconsin is one of the very few states that the Kaiser Family Foundation, for example, has mentioned has no gap in access to coverage. We don't want to see that reversed while we're trying to change this. So what can the federal government do to kind of assure us and then to make sure that we don't experience those gaps?
First place is to recognize that changes of this type take time to implement. We saw that with Part D legislation in Medicare. It was passed in 2003. The early period, 2004 and 5, people had discount cards, and then the actual purchase of Part D policy started in 2006. It had only about a year or two of some bumpiness, nothing like the exchanges, and it has more or less been okay. I just reviewed with you that it took 2011, 12, and 13 to try and get ready to basically pick up what started out at 8 million people and is now maybe 11, maybe. We'll see when we get the final numbers in the exchanges. Those were a lot of years, and so your concern about how long it takes is obviously appropriate. The last two examples have said a year or two is not unusual. It's why it's important to be as clear in legislation that is passed, say, in the next 6 months about the timeline, to try to reduce the uncertainty for insurers and states about how long what goes on now is likely to stay in place, and as specifically as possible, what will take its place, and to recognize it could indeed be 2 years in an actual transition, because it was for Part D Medicare, and it was 3 years when it came to the Affordable Care Act. And oh, by the way, it would be hard to come up with a more bumpy rollout than happened in October of 2013 when the exchanges opened. I don't know how Wisconsin did in those first 5 or 6 months. My office is in Maryland. I had been on their Maryland Health Commission for 6 years. It's a very sophisticated, technically sophisticated state. It was unbelievably screwed up. I say that only to say, watch out for the interim and how much clarity or lack of clarity exists. You're correct to worry about it. I mean, all of our experience says we better allow for 2 years transition, and we better assume that it'll be a little bumpy. And the more specificity we can have, or the more state discretion, which is more likely with Republicans, a lot more deference to state decision-making rather than federal requirements. That's what you'll have to look at the legislation. And if you don't like what you see, as I said, I believe, especially in Medicaid, that I cannot imagine a Republican Congress passing legislation that a majority of the Republican governors and legislatures don't want. That's what happened in 1996. They were talking about block grants. The Republican governors and legislatures were not interested in going there. It was too much risk.
Okay, thank you very much. Do we have some questions for Dr. Wilensky? Please go ahead.
Yes, hi, Dr. Lewinsky. Well, my name is Denise Wilensky. My name is Denise Rundy. I'm really happy to hear you speak. You spoke a lot about the reduction in costs of healthcare and attributed it to a number of things, primarily related to the economics, which makes sense, being that you're an economist. I was really hoping to see some change in the delivery system as part of the Accountable Care Organization. You mentioned the Marshfield Clinic. I think you could speak to the Cleveland Clinic, the structure of Kaiser Permanente, the more integrated delivery systems, and the high cost of what some people would call feudal care, or high cost of unnecessary, and I think you get the idea. And some of the changes I think that we see in healthcare, the consolidation of systems, integration of care, I think was driven in part by the accountable care proposed reimbursement. And I don't know that we've seen that much, as at least I anticipated, and to what extent that did or didn't contribute to costs. I'm just wondering what you've seen from your perspective.
We are still very early in this process, which is unfortunate. It's why I describe the Affordable Care Act as primarily expanding coverage and reforming insurance in the individual market and the very beginnings of trying to change the delivery system, most of which were focused on encouraging some demonstration projects that involved bundling of payments for orthopedic procedures, joint replacements. A cardiac bundle is just starting for bypass procedures and 2 or 3 other procedures. It is amazing to me how slow this is. When I was running Medicare now close to 25 years ago, we had a bypass demonstration that involved up to 10 sites that was very successful. Went on for 10 years and then it just petered away. We know ways that appear to provide higher outcomes and the same or lower costs. You've indicated some of them. I'm a big supporter of integrated delivery systems. I'm a director of Geisinger, which is in central Pennsylvania, integrated delivery system that is like some of the others that you have mentioned. The question is how to encourage that to form. You can push a little with regard to bundled payments, although there's a debate about whether or not these get in the way of going to a fully capitated payment where you take care of all of the care of the individual. And I think there's some legitimate question here. Most of the slowdown in spending that we have seen thus far is not because costs are lower. It is mostly because of the slowdown associated with the global recession and the fact that Medicare is simply paying less to hospitals, nursing homes, home care, and having Medicare pay less is not the same as having costs go down. Ultimately, it's not sustainable unless costs can go down, because there will be too much pressure in trying to shift costs elsewhere or push back politically. It really is where we need to go. I have been writing about and speaking about the time that we need to make some changes in how we reimburse and stop doing these demonstrations. I think demonstrations were fine for a few years. We need to make some decisions and change for Medicare, where the federal government controls things. Private payers are attempting to try to go into the value, not volume mode, but Medicare is a big payer and can help it. Medicaid, of course, outside of long-term care disability, has long been almost entirely into a capitated at-risk system because most states found it easier.
All right, we've got just a couple more questions here. First, Donna.
Hi, Dr. Wilensky. Donna Friedsam from the UW Population Health Institute. Thank you so much for being here this morning. Just want to ask you if you could briefly comment on states operating high-risk pools, and also about selling insurance across state lines and the role of state regulating of health insurance, since those seem to be emerging ideas for reform, repeal and replace?
High-risk plans have had a bad reputation, primarily because by definition, high-risk pools mean you have everybody in there is a high-need, high-use individual. That's why you're there. And that means requiring substantial subsidy, even if, as you should, you require some meaningful contribution from the individuals covered. They have typically not worked well in the past because the states have not been willing over time to subsidize them at the level that they need. You have to be very careful how you define who's eligible. You don't want to make it so attractive that you pull out of either the employer group or the individual market group individuals who ought to be there who are not so high spending or ill as to require very separate provision. So you will do that. You will cause your own problem if you make it too attractive. So it is going to be a delicate balance about how much they pay and where they get their care. You want to get the job done, but you don't want to make it so attractive that people will be inclined to drop their individual coverage if they're sick and go into the high-risk pool. You may choose to have safety net providers or designated providers who are good at providing a major sophisticated care but at an efficient expenditure, be the designated place for where people in high-risk pools get their care. So the two warnings are they can work if you subsidize them properly. You need to be very careful how you structure who's eligible so you don't mess up the remaining risk pools for the individual market and the group market. With regard to the capturing some of the spending, was that the second part of your question? Oh, no, the cross lines.
Right.
The reason there is some ability to do this anyway, I don't object to it. I don't think it has a lot of power there. The main reason you see different expenditures per person in different states are two unrelated issues. The first has to do with state-mandated benefits. A number of states, particularly in my part of the United States, have a lot of required benefits that are very expensive. When you can buy insurance across state lines, most people assume that would mean you could buy a policy that didn't have some of those expensive benefits. The question is maybe dealing more directly with that issue. The second reason that health care is cheaper in some places like Wisconsin, Minnesota, Utah, is a different practice style by the physicians and hospitals that are there. But if I am in Washington or people here in Maryland buy a policy from Wisconsin or Utah or Minnesota, unless we're actually willing to go there for our care, we will get care from physicians and hospitals in our local area, and they will continue their high spending ways even with a different policy. So I think people confuse why spending is so much lower in some places than other places, and I don't think it has the kind of payoff that some people attribute to it. So I don't object to it, but I would say don't count on that having a big impact either. There are some people who worry that you will also lose protections. States vary in how much they involve themselves in what insurance can or can't do or must do, or et cetera. States have different views about that.
Thank you very much, Dr. Wilensky. We really appreciate your time. I want to try to stay on our schedule here. We got quite a few other speakers. Once again, we appreciate your coming online with us today, and we're going to do our best to send some snow your way so you can kind of reminisce about your time in Michigan a little bit, so here in the Midwest. Thank you again. Okay. Our next speaker is Michael Heifetz. He is Wisconsin State Medicaid Director who oversees multiple programs that serve 1.2 million Wisconsinites and have an annual budget of over $8 billion. Prior to Michael's appointment in October 2016, he served as a State Budget Director at the Department of Administration, which I think means he's gone from the frying pan to the fire. And then prior to that, as Vice President of Government Affairs for Dean Clinic and SSM Healthcare of Wisconsin. So, Michael, we'll turn it over to you.
Thank you very much. It's good to see a lot of familiar faces around the room that I've interacted with over the years as colleagues and such, and I definitely appreciate some of the leaders of the Medicaid program being sprinkled about. I'll look for shaking heads violently if I'm saying anything that's just clearly false. So you can't shout out that it's false. You can just kind of give me a sign. I'm a little under the weather, as you can probably hear, so you are literally this morning getting Heifetz on steroids. So with that, let's go to the fun stuff. I'm going to give you first an overview of Medicaid, not that you don't all know significant portions of it, but just some of the basics that will paint the picture of the challenges that we have in Medicaid and just the basics of it as we look at what could be significant reforms coming in the next few months and or years. So you can see some of these data points. The key point is children are a huge amount of our caseload, 39%, but they are our cheapest to pay for. So then you see the elderly, blind, disabled population, and you can see the exponential increase to cover the services that those members need. And here's another way of looking at that larger Medicaid budget. You can see various categories. This could be broken down 100 different ways. This is just one, but you see various aspects of this. I will highlight prescription drugs as well. You see that's well over $1 billion, about 5 lines down, 13% of our total, but that trend line is not a good one if you're watching the budget, which everybody in here is, and I'm a former budget director, so I can't really stop in that regard. The line below that is drug rebates. So we do very well in how we purchase drugs for our members. We take advantage of various rebates through various programs and consortiums. So I throw that out to folks, and I was one of them who always used to come to Medicaid and say we could do this for you cheaper. So we're still willing to listen to that, but in 15 years of this, I haven't figured out a better way, but we'll still listen to it. You see a number of other things. The Part D clawback, don't ask me to explain how that actually works. It just costs us money significantly and can go up. And you see a few other things that get a lot of attention. Federally qualified health centers are very important, serve a very important portion of our membership, and serve them in places where they otherwise might not get care. But in the meantime, it's a smaller component of our budget. So it's just interesting as Medicaid director and as watching this stuff for 20 plus years, what gets attention versus what are the bigger drivers in our world. And the administrative costs, of which I am a part, full disclosure, are significant, but you could eliminate those, and we have not addressed any component of the problem. And here's just an overview of how our membership has grown over the years. And you can see the jump when we went from Affordable Care Act and Wisconsin's unique approach to the expansion. You can see the enrollment and the cost going, and we have finally stabilized. I think for a few years there, we were searching and searching for childless adults and kept finding them, and apparently we have now not found them anymore. So those numbers did exceed projections, but that's okay because the folks who need it are getting the coverage. Here's a breakdown. As I mentioned, the elderly, blind, disabled, they are a significantly smaller component of our program and our membership in numbers, but not in cost. And they do include the dual eligibles. That's 86,000 members that cost us $3.2 billion. So even when folks come to us to save $1 million or $2 million, which is important, and we will be responsive in that regard, that is a dilemma that needs to be addressed to ensure that those members and future members will have those services available without it crowding out every other component of a state budget. You know some of these cost pressures. I mentioned the pharmaceutical costs already and the specialty drugs. Hep C gets a lot of attention. It's also very expensive. Any of the biologics and cancer drugs are also very expensive. I won't get into the debate of how far they extend life or the clinical studies and those types of things. Just know that they're not 10 grand a month anymore. They're even more than that. And it's a dilemma societally and also for the program. Our caseload growth also can drive a lot of that. I'll get to that a little bit in a moment. I mentioned some federal mandates, the Part D premium fluctuations. You were probably reading about that a few months ago, where we were going to get hit with a sizable bill from the federal government in that regard. That was relieved a bit by some congressional action before the end of the year, so that was constructive, but still a risk. And I mentioned demographics. Folks tend not to think of this very much, so don't take this the wrong way, but as a state, we're getting old. Really, if you go north of, someone's going to have to remind me what the midpoint is of the state, whatever that highway is. I'm a Madison kid, so I don't know it. And it's really elderly and such above that line, and the trend shows that that population is decreasing overall, but getting older at the same time. So that is going to be a dilemma for our program. So not a lot of people get interested in demographics. I don't know if I ever was until this job, but it is important for our state. So these are some national statistics. I'll get to some Wisconsin Medicaid examples of them momentarily, but you've seen all these things, right? 20% drive 80% of the costs in whatever the dynamic might be. We are in line with that, but it echoes a lot of the dilemmas we're having with our dual eligibles and other components of our membership that are the so-called super utilizers, whatever name you want to use. They need services. They need those services to be coordinated. I'm something of a product of a integrated model, coordinated care model, which certainly could use improvement, but overall clearly needs to be where we're heading. And I think Dr. Wilensky mentioned how fee-for-service still drives the national system. It doesn't really drive our system to that degree. We're 70% managed care, but in our higher cost populations, we are not, and that is a dilemma that ultimately this state is going to have to address in whatever fashion. It can be smaller steps, but it does need some improvement for us to have these programs and services be sustainable. You know this too, but I like to remind folks of the fee-for-service versus the managed care world. Fee-for-service is exactly that. Folks, providers provide services, state pays for them, barring any fraud types of those types of issues, which we're discovering can be prevalent. And then managed care is a different model where we pay folks for take care of folks, and you know that, and a lot of you around the room are in that world, and that's very much appreciated. I've seen places where, frankly, we can be a little more aggressive in holding our managed care partners a little more accountable, driving quality metrics even further. Dr. Wilensky expressed some disappointment in the Affordable Care Act regarding quality and payment reform. I share that disappointment. It can be much more aggressive for us to be 6 years into the Affordable Care Act and not have significant payment reform or significant results from the Centers for Medicare Medicaid Innovation is disappointing. She mentioned demonstration projects. Right, there's supposed to be demonstration projects that show something works, and then we're supposed to implement them in a broader fashion if they do. So I'm just not seeing that happen. Coming from a regional system here, I know the difficulty of even spreading things from one clinic to another, but it can be done. And when we see other folks doing things, we should be modeling the good behavior and the things that are working. There's so much research out there, and it doesn't look like we're moving the needle as much as we should. And remember that the benefits are the same in each system, so it does not have to impact the member. They will still have that benefit level, and it can improve their care if things are coordinated better. Here's another way of looking at our overall challenges in the growth, demographics, et cetera. So sorry for the small print below, but you can see that we're assuming a 5.3% growth in costs annually going out 10 years or so. That may or may not be exact when we get there, but the elderly, blind, disabled members are comprising 64% of our expenditures in this current fiscal year, representing less than 20% of the caseload. So you're familiar with some of that data, at least conceptually, but it's data that we deal with daily that my team is always reviewing and bringing forth suggestions for improvements, and we expect to make such improvements as we move forward with good partners in the community. And again, children comprise less than 10% of our costs, but 39% of our caseload. So it's fantastic that we can cover them, but they're not driving the cost dilemma. All right, so before I go to there, you can see some of the challenges we face. Some of those are pretty positive challenges in that we're just trying to serve an expanding population and maintain those services and benefit levels. We have a strong program. It performs well. It can always use some improvements, but we're doing reasonably well for our 1.1 million members and hope to continue to do that even as change comes about. So I'll shift to a few slides on entitlement reform, and this will be really a waiver discussion, so I have to give it some qualifiers. So first of all, it is a waiver, meaning we can't do it until it's approved by the federal government, whoever might be in charge at the time. And there are numerous other qualifiers to that process. So they drive that process. They can disagree with specific provisions and put conditions on any other condition that we're trying to seek. So it'll be a process that we've already gone through in this state over many years of entitlement reform going back to Tommy Thompson, if not before. So it'll just be another one of those types of conversations. We don't know where the block grant debate fits into that just yet. I've had people ask me, well, what do we do with that waiver once you get a block grant, whatever the waiver might be? And we don't know the answer to that. I'm struggling with the concept of a block grant and still having waivers. But that's a dilemma that will need to get worked out through the legislative component of this with input, as Dr. Wilensky said, and I hope is true, strongly from the governors, who will clearly be more accountable for a lot of this and are up to that challenge. I have to bore you with that 1115 number. We have so many numbers of these waivers, 1915, CA, 1332, I don't actually think we do. I'm just using these because my team throws them at me all the time, just reminding them that I actually do listen once in a while. But it's an alphabet or numeric soup of things with the federal government. So we have 5 policies you see in front of you. The last one, drug screening and testing, not new. And frankly, none of them should be new. They were all part of the Act 55 debate a couple of years ago, as the legislature and the governor concurred on pursuing waivers in this direction. And with that, I'll jump in. So again, any details are not sacrosanct. They're more illustrative and based on what we're seeing in some other states that have pursued similar things. They're all subject to change. We have not submitted this yet, so you're getting a nice preview, but it is not absolute. Imposing premiums. So we already have copays and things of that nature. You see some data points there. They are largely driven by how other states have approached this successfully and by the 5% maximum that the feds would let us assess folks in the Medicaid program, 5% of their income. So there are constraints on the program, reasonable ones that we can see. So you can see what those premium amounts are. They, to some of us in the room, they're nominal, but they're not nominal to our members. And the design is clear so that they will take a little more control of their own healthcare coverage situations. And they're just as rational, our members, as anyone else is. So they understand their care and their needs, and they'll understand the impact of a premium. There will be some consequences for non-payment, which we wouldn't anticipate being the biggest problem. But you can see what those are. And again, those will be discussed further as we get into a session with CMS. This provision received a little bit of attention during the last budget debate as well. The health risk assessments that we would be doing, which I'll talk about in a moment, but feed into this, a higher premium for enrollees in risky behaviors. So we could spin that a little more positively, that we would actually be rewarding folks with a lower premium for doing the good things, not smoking, keeping their weight at the appropriate place, things of that nature. But there are national organizations that measure these, so we will be using rational metrics and approaches to this. and we will use that health risk assessment to identify folks. And we think that's a pretty normal thing. I know I get this type of thing when I go see my doctor, quite a bit in the last 2 weeks. So we think it's pretty straightforward. Folks shouldn't be smoking, and if they are, we shouldn't be paying more for their coverage for it. As we get to the health risk assessment, that would fall to our health maintenance organization, so we will obviously work with our partners who cover 75% of our folks now to work through this. They are already skilled at this, and we don't view it as a major impediment to their delivery of good care. And we will use those elements that we defined through this process with CMS, and we do expect our members to complete that HRA. And if not, then they would get the higher premium. So it's more of a carrot, do good things and get a lower premium than it is a stick. And you've heard the discussion over the last couple of years in other entitlement programs with the time limit. This would approach it in a very similar fashion, 48 months, starting from whenever this would go into effect. No one would be already facing any time off of that clock if they're already in the program. And there will be exemptions to this, so it's not as harsh as some may think it is. And we'll see how responsive CMS is to that. So some of those exemptions include a work component, so folks who are in a job or in training programs would not have the clock ticking. And there are some exemptions now that we are pursuing through the food share program that you see in front of you that we would likely mirror in this program as well. And lastly, the drug screening and testing. You're familiar with this from the debate with food share, so that is potentially coming. And we would use similar screening tools to assess the need for further testing as well as treatment. A number of states that are pursuing this do not do treatment. They simply test and react. We approach this much differently, much more realistically and compassionately. It is designed for moving folks from dependence to independence. So if there is a drug problem, getting treatment is obviously important, and that is part of this program that often gets missed in these discussions. So that's the overview of what will be submitted eventually in a much more dense form than what you're seeing here today, and likely with some changes from what you're seeing today. But this should give you a great idea of where the governor sees these programs going and how he'd like to continue that movement from dependence to independence in these programs. There are certain populations that will be in Medicaid for a very long time. You saw those exemptions. There are certain populations that are not supposed to be in Medicaid for decades at a time. It's supposed to be something that helps folks when they're going through some hardship for a period of time. And then we hopefully help them through that hardship and they're back into a different program than our government one. So I'll shift for a moment with another slide on the federal components of reform, potentially, Medicaid reform, and some things that we're thinking about. This is, it's really just a few considerations that we're looking at. And sorry, I mentioned the treatment. So it's a few considerations. This is not a complete list by any means, and Dr. Wilensky mentioned a few of these as well. So I put hybrid up there on the top line, block grant per capita, which she mentioned, and hybrid is sort of my invention. They don't have to approach every population the same way. So we may engage a different kind of conversation depending on where we see things heading. This state has different challenges and opportunities than some other states, and we will be sure to articulate those to our friends in the federal government, whether they are elected or the appointed or more in the bureaucracy as well. So there are multiple approaches that Dr. Wilensky mentioned, and we share that opinion, obviously. She also mentioned the baseline. And a lot of you who've been around as long as I have will remember the maintenance of effort issues with welfare reform and things like that, where Wisconsin was clearly punished for going ahead of the curve on some reforms. And that was difficult, and we're probably still paying for that in some ways. So we want to ensure we are not penalized for our unique approach to achieving zero coverage gap. So sounds sort of obvious that we should not be penalized for that kind of thing, but the federal formulas work oddly at best. And I could go back years and blame senators and representatives of various parties, but I won't do that here today. But we haven't always done the best, and that needs to be improved upon in this process for us to have a great opportunity to improve our care and access for our residents. The indexing is also an issue. Inflationary indexing is an obvious metric. Medical indexing is another one. I don't know how realistic that one is, but it's a reasonable ask. But that's another component that needs consideration. Dr. Wilensky also mentioned the timing and phasing of this. Governor Walker mentioned it in his letter to House Majority Leader McCarthy and the House Majority Leader's colleagues. So go ahead with repeal and replace early, but give us a transition period of rational, practical length. And I appreciate the governor saying that, since I obviously share that, being the one responsible for implementing what could happen. There's also the overlay with the insurance market. So these don't often get discussed in tandem, but the Office of the Commissioner of Insurance, Commissioner Nickel and I are discussing these things all the time on how any insurance reforms that could result from an Affordable Care Act repeal would impact our coverage opportunities in this state, along with the Medicaid piece. So they could be isolated, but probably not so. And I mentioned the dual eligibles. There is significant talk behind the scenes in Washington about that dilemma. Medicare pays a huge component of, not a huge component of it, pays a component of the dual eligibles. Medicaid has a heavy burden. The feds drive the program, but we burden the cost significantly. So there's an imbalance there that needs to be addressed. No one has solved that dilemma, and the Affordable Care Act clearly hasn't either. The regulatory relief is a broader category, but it really can include what Dr. Wilensky mentioned about CMS and their process. Their waiver process is cumbersome and lengthy, and by the time you get to something, you might then have a new administration that might have a reverse opinion on something. So it is a dilemma, and we want to work that into the conversation significantly with this block grant component. And when I say block grant, I'm not specifically saying block grant or per capita. I'm just using it as a generic term. Excuse me. So, but how a waiver or how CMS's regulatory authority works in a block grant needs to be defined. It's hard to imagine that there's a block grant without basic parameters around it. So we will see what those end up being. And I mentioned the clawback and the Part B premiums, and there are some others where the feds are imposing some things on us that, frankly, they just shouldn't be. It's not contributing to our members' health and well-being, nor is it contributing to the taxpayers' affordability factor.
All right.
So
Very good.
that's the wrap-up on that. Look forward to the other speakers and discussion.
Thank you very much, Michael. Our next speaker is Dr. Justin Sydnor, the Leslie P. Schultz Professor in Risk Management and Insurance and an Associate Professor in the Department of Risk and Insurance at the University of Madison School of Business. Dr. Sydnor is the Associate Director of the University of Wisconsin Center for Financial Security and a Research Associate of the National Bureau of Economic Research in the Healthcare Program. His research interests include behavioral economics and studies of decision-making in insurance markets. All right, Doctor.
All right, thank you. I'm very happy for the evidence-based health policy initiative for putting this together today. What I want to talk a little bit about are high deductible health plans and health savings accounts, and I promise I'll try not to make this too dry. There's a lot of uncertainty, obviously, about what's coming in healthcare reform, but one of the things that we consistently hear from many leaders, President-elect Trump, Paul Ryan's office, Congressman Ryan's office, in their healthcare proposals, is an increased interest in using health savings accounts as one potential way of financing healthcare going forward in reforms. So I want to take a little time to do a quick overview of that and discuss a bit of the research we have, because we actually have a fair amount of academic research on how these things are working. So for those of you who aren't familiar, the basic idea of a high deductible health plan with a health savings account is, if you contrast it with a traditional plan, in a traditional plan you might have a fairly low deductible and most of your health spending at the doctor or hospital will be covered by insurance. And the trade-off there is that often comes with a fairly high premium, represented on this slide by that kind of big stack of gold coins on the left. The idea with a high deductible plan paired with a health savings account is that if you take a higher deductible, so let's say a $2,000 deductible, those costs must be borne by the patient themselves before the insurance kicks in for the year, but that leads to a reduced premium. You're paying less for the insurance. And that savings then can potentially be set aside and used to pay for those out-of-pocket costs. And so these are paired with something called a health savings account, which is a special type of savings account for funding medical expenditures. And there are a couple of important special features of these health savings accounts. So the first is that deposits into it are tax exempt. And that's important because it makes the money that you can set aside to pay for healthcare directly in a health savings account equivalent to paying premiums, because most people who get employer-sponsored premiums, those premiums are not taxed. And so this gives a tax equalization between money you're paying for insurance versus money you're going to pay out of pocket. These accounts can only be used for medical expenses, but the definitions are pretty broad of what that includes. Importantly, and especially relative to some people who have experience with some other types of medical savings accounts in the past, the unused funds in these health savings accounts roll over indefinitely. So these are potentially a savings account that can be used to fund higher healthcare costs later in life, and there's no risk if you put money aside in them that you'll lose it at the end of the year. Any interest earnings that come from those savings are also tax exempt. Now, these are increasingly common, as Dr. Wilensky mentioned, in the employer-sponsored space. So for people who get insurance through their employers, the fraction of employees enrolled in these high-deductible health plans with a savings option, and there's one other sort of version of a savings option, but the health savings accounts are the most popular, has risen quite rapidly in recent years. So now it's just under 30% of national population, according to Kaiser Family Foundation, and that was up from 4% 10 years ago. So this is an increasingly common thing, and as we think about it, what we should think about, I'm an economist, so I always talk about, on one hand and on the other hand, trade-offs and costs and benefits. So there's kind of three big potential rationales for why this type of structure might be popular. And then after this, I'll talk about the potential downsides of this sort of structure. So the first is that this might allow you to set what we might call optimal insurance levels. The basic idea is that having some level of a deductible likely makes sense for most people because it allows you to avoid paying an insurer for costs that you can afford and cover yourself. And any money that you pay for healthcare through an insurer is going to have at least a little bit of markup to cover the costs of those insurers doing business and potentially profits. So there can be a little savings there by having some way of setting aside money and paying for some things directly before the insurance kicks in. Then there are probably the two most talked about things that you hear in policymaking around why you might want these types of structures. In particular, why you might want people to be paying some of their costs directly and maybe funding it through a health savings account. And those are that these sorts of accounts and pairing with high deductible health plans may help reduce health spending. And people talk basically about two avenues for that. One is that it may create some incentives to avoid lower value care. The idea here is that if my doctor presents me with a plan to get maybe a questionable MRI for lower back pain, say, if that's a fully insured cost, I may say, sure, I can sit in the MRI. But if that money's coming out of my own health savings account, I may be more likely to question whether it's actually valuable. The other avenue of potential savings that people talk about here is that, again, by having your own money on the line, this may encourage some comparison shopping. So it may encourage you to look around for a cheaper provider of that MRI, say. And that, in turn, may support sort of more competitive insurance markets and help hold down costs. Now, On the flip side, there are some potential concerns with this type of structure. The first is just the basic concern of financial risk. How large those deductibles are is an important question, and there's a difference between a $1,000 deductible and a $20,000 deductible that's pretty obvious, but there's also sort of a sliding scale in there. And in particular, if we think about if the money that people have set aside in these health savings accounts is too low relative to their potential health spending, they may be faced with a lot of financial risk and some hard trade-offs then about how to spend their money and what sort of health care to access. A second sort of important thing linked to that that's a little more subtle is what I would call inefficient risk pooling. So the idea is there's a reason we band together and have insurance and we don't all try to set aside lots of money to pay for everything directly. And that's that it's very inefficient to have to set aside everyone with their own $10,000 health savings account all the time to pay for risk. If most of us aren't going to use that amount of money each year, society would probably be better off having more money sort of freely spent on investments and other things and not tied up in these health savings accounts. So again, this is a question of how large the deductibles are and how much money we end up needing to set aside in this way. There's also some concerns about chronic disease management. So when people have to fund their own healthcare costs, they may potentially pull back on managing chronic diseases, which can have a personal effect, but may also lead to bigger societal costs as well, because the long-term effects of not managing a chronic disease end up being borne in higher healthcare costs through other programs, Medicare and Medicaid in particular. And then the final one is that while in theory these accounts can promote competition and searching, there is a concern that we have what you might call underdeveloped market tools in place right now. So we're transitioning very slowly from a system where everyone was fully insured and everything was fee for service to these alternative methods. And at the moment, in a lot of settings, it is very difficult actually to price shop and comparison shop, and that the systems just aren't that well set up for that. And so that's a potential policy issue and a practical challenge. So, this brings up some questions. What do we actually know about these plans now that we've seen a rising number of them working? And I wanted to touch on a couple of things. So the first thing I wanted to talk about is just this question about the level of financial risk. And in particular, what you see if you listen to sort of policy discussions around high deductible plans and health savings accounts is people are very concerned about how exposed people are to financial risk. And there's usually this pretty direct tie. People talk about high deductibles and rising financial burden on families. The main thing I want to argue is that we should be a little more careful when we think about that. It doesn't necessarily need to be so. And I want to give an example of that from our own sort of situation here, at least my own. So I have a health insurance through the state group health insurance program for state employees, as some of you in the room likely also do. And for us, we have two options. We can either have the standard plan, or we can have a high deductible plan, and they're just different in the sort of financing. And our high deductible plan has one of these health savings accounts. Now, what we can think about is how much financial risk does a family like mine have in these two different plans? So in the standard plan, which they call the It's Your Choice health plan, I can think about my worst case scenario for the year. And my worst case scenario would look roughly like this. I have to pay some amount of premium every month out of my paycheck, and that adds up to $2,640 for a family plan. Of course, the state, as my employer, also pays into premiums, but this is my cost. And then the out-of-pocket limit, what I might have to pay out of pocket if somebody in my family needs a lot of medical care, is $2,500. So for the year, the worst case spending scenario for me is about $5,000 on medical expenses. There are a few complications here and there, but that's kind of the basic picture. Now let's think about the high deductible plan. The high deductible plan carries a $3,000 deductible and has a maximum out of pocket of $5,000. And so at first you might think that that exposes me to a lot more financial risk. But the reality is actually rather different. My total annual employee premiums, if I choose that high deductible plan, are much lower. They're $972 for the year. So that's about a $1,500 savings in premiums that I get if I choose that plan. Now, my out-of-pocket limit is higher. It's $5,000. But the state is also going to put into my health savings account $1,500 for me that I can use to fund healthcare. And that's a pretty typical arrangement, that these health savings accounts are often partially funded by an employer. And this has been discussed also in policy provisions that refundable tax credits, for instance, could be deposited directly into health savings accounts for people. What that means for me is my worst case spending scenario here is actually lower. So worst case and best case, I save money with the high deductible plan, given how ours is set up. Now, for those of you who are in this system and didn't choose that plan, I'm sorry I didn't bring that information to you a couple of months ago, but we're working on that. Now, the key thing I want to argue here is that this is not actually that rare. What we see is that this sort of arrangement where the high deductible health plan, once you consider the premium savings and the type of contributions that employers are making into health savings accounts, often leads to actually lower financial risk. In fact, a recent survey I did with a graduate student that we hope to publish soon suggests that may be true in about 2/3 of private employers, that it looks like this, that the high deductible plans are actually giving lower risk. And the basic lesson here is that the nature of the risk that people are exposed to in these things depends on the details of how big the premiums we make, how big the deductibles are, how big the premium savings are, and what sort of contributions we give people into HSAs. So you can't just sort of blindly talk about one. The other thing I wanted to talk about quickly is, what do we know about the effects on spending and healthcare use when people get these high deductible plans paired with health savings accounts? And fortunately, we have one really excellent study that came out in the past year from a number of leading academics who studied a large firm, a very large employer, that had what we would think of as a very powerful natural experiment. So this was an employer with a very big population. Their employees are highly educated and actually earn fairly good incomes. And so this is a population that should be able to handle these things well, potentially. And what they went from is an original very generous plan where the employees paid no premiums and faced no cost sharing. So this is essentially the best insurance you could have, the most generous insurance. And then they switched everyone to a high deductible health plan with a $3,000 deductible and a $6,000 maximum out of pocket. Importantly, the firm contributed $3,000 to their health savings account. So these people had a lot of money set aside to potentially pay for those out-of-pocket costs. And they were given a cutting-edge tool to search for lower medical prices before they got care. And so this might be the ideal situation. What they found is that this graph shows you the spending at this firm over time, where the red line is when they instituted this switch. And so what you can see is there was a clear and sudden drop associated with, in medical spending associated with this switch. And they estimate, after doing some sort of fancy cleaning up of the data, that it's about a 12% reduction in total healthcare spending from this switch to a high deductible plan. And in this case, they exposed people to some more financial risk, but not necessarily hugely more financial risk. So this is the potential upside, the reduction in spending. However, they can also look at how that spending was reduced. What did people do? And they have a couple of key findings that I think are very important as we think about moving forward with more of this type of plan. The first was they document no evidence of consumer price shopping. So despite the fact that these people had a very good tool, they were not effectively using or able to use that tool to shop around for prices. And so the savings are not coming from reductions in the prices of the care people were getting. Instead, there was just a very broad pullback on the use of medical care. And unfortunately, that also included a lot of reductions in chronic care and preventative care. Even though the preventative care was 100% covered under the plan, that didn't even require things. And that also created some very inefficient patterns of healthcare across the year. So what they found is early in the year, when people were under the deductible, they weren't going to the doctor very much. And then for people with chronic care, once they hit the deductible, they started going to the doctor and getting more appropriate care later in the year. And that sort of negative effect of these things has been corroborated in a couple of survey studies. So in particular, the use of price shopping tools is quite limited even when they're available. So people don't use them or they're sort of not very effective. And the other thing is that there's very low awareness that preventative services and chronic care are actually covered when you're under these things. And so there's some big information gaps of helping people understand what care they can actually access. So let me just quick finish with what I see as a couple of questions and challenges this sort of research tells us for policymakers. So I think if we think about issues highlighted by this research, the first is that there clearly needs for some reforms to bring out these consumer-driven benefits if we're going to move more strongly in this direction of having people shop for healthcare. Right now, in the best examples we have of this, it's not particularly effective. And I think there are a range of things we might need to think about if we want to go in that direction to make it more effective. And to facilitate better communication about how these health savings accounts are supposed to work and how people can navigate them. And then there are a couple of issues where I think we have very little existing research, but that as we expand in this direction more, we need to think a lot more about. The first is, how the increased use of this type of arrangement is going to affect how insurers and plan administrators negotiate prices with providers. So right now, when a health insurer is on the hook for all of the spending, they have an incentive to negotiate low prices with all of their providers for all of their spending. As more spending shifts to the individuals and insurers are more on the hook only for catastrophic large hospital incidents, that changes the nature of their incentives, and we don't yet know very much about how that's rippling through. And we also need to think a little bit about, to the extent that people do not fund these health savings accounts fully, this may create some more problems with medical bankruptcy and uncompensated care at hospitals that we need to deal with. And the final piece that I didn't put on here, but given what some discussions that came up earlier that I should also mention, we also haven't yet fully figured out how to accommodate this type of arrangement of individuals making lots of payments through health savings accounts with these more integrated care type models where we're imagining that we won't pay people for services. So how an individual uses these health savings accounts to finance an integrated healthcare plan is also still a little bit up in the air. Okay.
Very good. Thank you, Doctor. Our final speaker, and then we'll go into a question period, is Donna Friedsam. Donna is the director of the Health Policy Group at the University of Wisconsin Population Health Institute. Ms. Friedsam has worked extensively on healthcare access and financing, leads a team of faculty and researchers evaluating Badger Care Plus, and directs the Covering Wisconsin program within the UW-Madison School of Human Ecology. Prior to joining the university, Ms. Friedsam served as the executive director of the Wisconsin Primary Healthcare Association.
Thank you. Good morning, and I should note that normally I don't speak on these panels because the Evidence-Based Health Policy Project is within my portfolio in the UW Population Health Institute, but this topic happens to be also very much within the work I specifically do myself, and so I appreciate the indulgence of having an opportunity to speak with these wonderful and very distinguished colleagues on this panel. And I just wanted to speak very briefly, because I know you all have probably many questions for the other panelists, to talk about what might be happening while we wait. So I talk about, we are going to be waiting after repeal. There'll be some kind of a delay period, and after replace, there'll be some kind of a delay period. And what might calm insurance markets and assure consumers in these interim periods, such that the process can go as well and smoothly as possible. I want to remind people, as Representative Sanfelippo did when we started, that the governor, we have a very high rate of coverage in this state, and we have done well over the last few years of improving that rate of coverage. And in 2013, in fact, Governor Walker set a goal when he created the state's unique approach to entitlement reform, and his goal was to reduce the number of uninsured in the state by half, or actually setting a number to that and saying our state would reduce the number of uninsured by about 225,000 persons. And the date, he said, was by 2015. So I'm going to just set that out as a number to say that the state heavily invested in trying to reduce the number of uninsured over the period after the governor implemented his model of entitlement reforms that were put in place as an alternative to the ACA's Medicaid expansion. So during the transition phase that we're going to be going through over the next couple of years or months or whatever it may be, there's going to be a number of state interests that may be mutually supportive or may be in conflict with each other, depending on how things work out. We, I think, all are going to share an interest in retaining a viable and healthy non-group insurance market. There may be an interest in allowing Obamacare to expire with attrition from the ACA coverage, so not necessarily wanting to have people continue to buy into Obamacare policies because the program's going to go away. But on the other hand, we don't want to lose ground on the insurance coverage and meeting the governor's 2015 goal. So how do we handle all of these different interests? Well, just by way of background, today, as we stand, the most current information we have today is under the current open enrollment period that ends at the end of January. We have about 234,000 plan selections for the Affordable Care Act in this current open enrollment period for 2017 in Wisconsin. So that's how many people in Wisconsin will, assuming they effectuate their coverage by paying the first month's premium, at least that many people will have Obamacare policies in 2017. And that's ahead of last year's number. So we do see at least enrollment for this year on par or growing from last year. So quite a large number of people in Wisconsin do have these policies and will in the short term be depending on those. As well, a large number of insurance carriers participate in the ACA marketplace in Wisconsin. This is contrary to what we've been seeing in a lot of states around the country. In Wisconsin, we have 15 insurance carriers in the state offering multiple products, and 56 out of the state's 72 counties have at least 3 insurance carriers offering plans. So consistent with Wisconsin's relatively strong individual and non-group insurance market, we have relatively strong participation by insurance carriers in the Affordable Care Act's marketplace in this current year. And that's just a map showing the distribution of carriers throughout the state in the various counties. So we know that the number of people, 225,000 people enrolled in the Obamacare policies in 2016, about 84% of them depended on the ACA's tax credit. So people are very dependent on those tax credits that may very likely be repealed in the coming year. So there is going to be a question about how the 225,000 people that currently are depending on that federal financial assistance, how or whether they will be able to access affordable coverage through other mechanisms and what those mechanisms will be. As well, we know that consumers in that younger age range, the young invincibles, 18 to 34, make up about 26% of those who selected the Obamacare marketplace plans. So we want to try to keep those young invincibles somehow participating in coverage. We know that looking at Wisconsin's overall individual insurance market, about 2/3 of all people in an individual insurance plan in Wisconsin purchase them on exchange, meaning an Obamacare policy. So 225,000 of the total of 335,000 individual non-group insurance plans in Wisconsin are ACA policies. So that is to say, as it stands today, the non-group insurance market in Wisconsin is heavily invested in Obamacare. And again, about 84% of those plans depend on the receipt of federal subsidies. So we are very heavily tied to the Affordable Care Act in the non-group insurance market in Wisconsin today. And just to, again, reinforce how heavily we are tied to the federal financial assistance, this shows that, again, as most of the people in this room know, persons under 400% of the federal poverty level can receive that federal financial assistance. 84% of them participating do. And about 54% are also receiving cost-sharing reductions. And this shows that the substantial impact that federal subsidy makes on the cost of a premium. So for a 27-year-old with a household income of $25,000, if the premium is $304 a month, with the federal subsidy, it brings it down to $142 a month, or 53% reduction. Similarly, for a family of four, a premium may be over $1,000 a month. They get a 63% reduction in premium to a $405. So the federal subsidies have been very important for bringing these 230,000 people into the individual non-group market in Wisconsin thus far. And in terms of rural and urban participation, we know that rural consumers make up 30% of those who selected the ACA marketplace plans, which is higher than the relative proportion of overall residents in Wisconsin. Rural residents make up about 30% of Wisconsin's population. So we do have strong rural participation in purchasing Obamacare policies. So I'm going to skip this part about uninsured, except to say that we have seen, as well, similar to national, substantial reduction in the uninsured, 9.1% in 2013, down to 5.1% in as last measured in 2015. And I will say, contrary to what we saw nationally and what Dr. Wilensky pointed out, she noted that nationally, most of the reductions in uninsured came from expansions in Medicaid. But actually, in Wisconsin, it's the reverse. Most of the gains in insurance coverage in Wisconsin occurred through ACA marketplace coverage and increases in employer-sponsored insurance that likely happened because of the economic recovery. So just to show you here, the reductions in the uninsured, and you can look more in detail at these slides later when they're posted online, but the uninsured decreased by about 195,000 people from 2013 to 2015. It's about 38% reduction across all income levels, as you can see here. And how did the uninsured decrease? We had a substantial increase in employer-based insurance, and we had an increase in direct purchase health insurance, the 78,000 person net increase. But in terms of the net increase in Medicaid, that while we did have an overall increase because of the expansion to childless adults, we also had that was offset by a decrease because of the reduction for parents and caretakers between 100 and 200% FPL. So in Wisconsin, unlike nationally, again, I'll reiterate that the reductions in uninsured over the last couple of years were primarily based in increases in employer-sponsored insurance and increases in direct purchase of insurance through the non-group market, again, through Obamacare policies. So moving forward, most of Wisconsin's individual insurance market is now based on ACA products and federal subsidies. And the carriers need to file their plans by May 2016, which is tomorrow, for the next open enrollment period. So the questions that raises: will the carriers continue to offer non-group coverage in the absence of clear vehicles for retaining these consumers? And how will consumers understand what is available to them during the repeal and replace transition period? As well, will there be ongoing support for enrollment assisters who've been working with consumers to help them understand what is available to them? This has been a central part of what's been going over the last 2 years. So let me revisit the early slide. We have these interests. We want to retain a viable and healthy non-group insurance market in Wisconsin that 350,000 residents of Wisconsin have been relying on for their insurance coverage. We may have an interest in allowing Obamacare to phase down, maybe with attrition from the ACA coverage, but that may be in conflict with our interests to retain a viable and healthy non-group insurance market and our interest in not losing ground on the insurance coverage and in meeting the governor's 2013 goal. So let's just remember that the replacement plans that are being contemplated and are very likely to include health savings accounts and high deductible health plans, an increased use of incentives to promote consumerism and shopping, substantial changes to Medicaid, including the potential introduction of cost sharing similar to commercial coverage. We heard about that this morning from Director Heifetz. The potential purchase of insurance across state lines, and requirements for continuous coverage in order to avoid exclusion of pre-existing conditions. So these are all new and potentially challenging things for consumers. Could lead to a lot of confusion. And people are going to wonder how they're going to retain coverage, and also just listening to Dr. Sydnor's presentation, there are a lot of information gaps on how to do this, how to handle high deductible health plans, and how to strategically manage these new vehicles for getting covered. A couple of years ago, when the governor introduced his entitlement reforms, he and his cabinet, or I should say particularly the Department of Health Services, were very strategic and aggressive in making sure that the state was well prepared to be successful with those entitlement reforms. And DHS introduced a regional enrollment network structure, bringing in a broad range of partners that you can see in this slide, and working very hard, making great investments to organize the state, to reach out to consumers, inform consumers in all areas of the state about how the entitlement reforms would work, making sure that there were enrollment assisters, income maintenance capacity, worker capacity, and educational efforts to prepare consumers and communities for the changes ahead. And it resulted in a sophisticated network of regional enrollment network and consumer assisters that were supported by the Department of Health Services. And it was a noted effort. It received attention in some national write-ups. And the Commissioner of Insurance also worked very aggressively to make sure that licensed navigators and certified application counselors throughout the state were very well prepared to work with consumers and make sure that they knew how to work with insurance agents and brokers, and make sure consumers were going to get the kind of assistance they needed throughout the state to understand the entitlement reforms under Medicaid and what was available to them through the Affordable Care Act. So I guess what I would put forth for consideration, before I say that, I'll just say what that resulted in, and is summarized in this report that's online, a 2014 report, joint report of DHS and OCI, about the way that the two agencies worked with partners throughout the state to make the governor's entitlement reform effort successful. It was a massive undertaking, and it was a massive organized effort, recognizing how complex it was to make those transitions under the Affordable Care Act and under those entitlement reforms at the time. And I believe we're going to need an equally massive effort again to do that going forward. And I would just put that forward for consideration with the those are my data sources in case you want to wonder whether I made everything up. And just suggest that we're going to need that kind of an organized effort and that kind of workforce of people throughout the state to make sure consumers are well prepared for the significant changes ahead.
Excellent. Thank you very much for your presentations, everyone. You did a great job on this topic. We'll open up for about 15 minutes or so to questions from the audience. We'll do it in the same way, so if you go to the doors and to the people with the microphones, and then about 11:20 or so, we'll have Sam wrap up with a final question here. So go ahead, sir, please start.
Yes, this is for Director Heifetz and anyone. My name is Mike Miller. I practice addiction medicine at Rogers Memorial Hospital. And there's data that one of the big drivers of healthcare costs, especially in Medicaid, is the medical complications of alcohol, tobacco, and other drug use. And the price we pay for not recognizing addiction early. A study by the Center on Addiction and Substance Abuse at Columbia probably a decade ago suggested that up to a third of Medicare and Medicaid expenses could be on treating the medical complications of tobacco, alcohol, and other drugs. But we only spend 1% on actual addiction treatment. So most people in this room, when they think of drug testing, they think of employment-based drug testing, which is basically a gotcha approach. Let's go find somebody doing something society doesn't think is a good thing, and then when we determine they're doing something we consider naughty, let's just penalize them, such as not giving them a job, firing them, or something else like that. I'm wondering how it is, because we heard from Director Heifetz that what's happening in Wisconsin, he alluded to, is not a gotcha approach, but instead using drug testing, which may not be the most effective way, but using it as a way to identify people in need of referral to addiction treatment so that they can be treated and then not be having medical consequences, ICU and ER visits down the line. If that is the strategy of the administration and Mr. Heifetz's division, and that's a major reason to do this, how come we're not hearing more about that? How come there's not more in the public discourse? How come that the information that the media picks up on from governmental pronouncements is just, we're just going to drug test them welfare people? So I'm just wondering about that from a health promotion standpoint and a cost saving standpoint. Thank you very much.
Thanks for your question. And that's a great question. I can't interpret why the media does what they do. It's not productive for me to do that in this environment. So the governor's approach is the governor's approach. It's a much more rational, practical, and compassionate approach to actually helping someone move from dependence to independence. But in the meantime, we need federal approval to do a number of these things. So until they actually become reality, perhaps folks just can't grasp on to what's a pretty rational concept. And I will challenge your premise that it's all just gotcha drug testing. I did have a job that is not on my resume that did require drug testing, and it was directly related to my job. So the premise might apply in some cases, but I don't accept it on its face.
All right, we have a question over here. Questions? Oh, sorry, go back over on this side then.
Thank you so much to everyone for an incredibly informative morning. My name is Sarah Davis from the Center for Patient Partnerships, and I really appreciate, Ms. Friedsam, that you ended really with a focus on consumers and the kind of concern we should have about their understanding this complexity. We at the Center for Patient Partnerships share these concerns, and what I'd like to hear is what resources are available so that our lawmakers are deeply connected to patients and families and all Wisconsin residents' experience, so that as we move forward with policy change, we are absolutely taking into account what the experience is for real people. I think it's incredibly important with all population health to be looking at the numbers and to be understanding sort of the complexity for us all. But ultimately, this is about real people and health and really difficult choices. And I'm really concerned that folks are essentially going to stop getting health care because they get one bill that has costs they didn't expect and they don't understand it. And we're going to be sort of back at, at point zero.
Do you have a comment to make, or more of a comment than a question, I think, but.
No, it really is a question. What I want to know is what are the resources that we should be looking at nationally and locally to make sure that we're in touch with consumers. If folks on the panel don't feel like they know those, I'm happy to share what I know about, but I just want to make sure that we're deeply grounded in patients' experiences. And for example, the nursing department has a group called CARDS that can evaluate policy based on the experience of low-income users and help us to deconstruct and understand whether it's going to actually work for real people. But I'd like to hear what other resources we should be considering as policymakers.
Well, thank you, Sarah. It's, of course, so important that we make sure that consumers know how to work with the changes ahead, and that's important for the well-being of the consumers and for the success of the policy. I will note, as I tried to indicate in running through, I know I ran through the slides very quickly, we do have a workforce of enrollment assisters around the state now, both the formal workforce of agents and brokers, and then certified and licensed navigators and certified application counselors around the state that are the frontline workforce for trying to, as well as income maintenance workers for the Medicaid and Badger Care programs that are the front lines to educate, conduct outreach, education, and ultimately assist in connecting consumers to whatever coverage they, for which they're eligible. Navigators in particular have also taken on a role in health insurance literacy education and trying to make sure consumers understand how to use health insurance and engage effectively with health insurance and health care. One concern that exists going forward is with the repeal, anticipated repeal of the Affordable Care Act, what might happen to the navigator and certified application counselor workforce, which was authorized and funded by the an Affordable Care Act grant to the state, and whether there will be other resources to support that existing workforce, because it really is not the insurance agents and brokers, while very important, are not a sufficient resource to handle the number of people out there that are seeking this kind of information. And as well, there's a different kind of business model around working with consumers to connect them with commercial policy as those consumers who need to be tested for eligibility for Medicaid and the like. So that is one consideration that we are wondering about going forward, and how that enrollment assistance workforce will exist going forward.
Online question, Sam?
We probably have time for one online question, and it's for Dr. Sydnor. The question coming is, how does the financial risk look with a truly high deductible? The figure in your example was $3,000, but this individual is serving clients that have upwards of $7,000 to $10,000. So I think the question is, what does that risk calculation look like for a higher number?
Yeah. So I think that's a great question. The issue you run into with designing these plans is that it really does matter exactly what level of risk you expose people to. And so what we see, for instance, when we study the employer-sponsored space is that the nature of the risk facing the employee depends a lot on how the exact program is set up. So, I mentioned there are a lot of firms where the high deductible plans actually do not expose people to more financial risk, and if anything, less. But those tend to be the firms where the high deductible plans are just over the federal minimum for that high deductible classification. So these are cases with $1,500 or $2,000 deductibles. At firms where it gets much larger, and you rarely see something like $7,000 in a lot of the employer-sponsored care, but you certainly do within the Affordable Care Act exchanges, that level of risk is much harder to set aside money in a health savings account to cover. As we talked about before, if you thought about having a $6,000 or $7,000 deductible, in theory that means to finance it, you have to have $6,000 or $7,000 sitting around at any point in time in a health savings account. And without a lot of financial assistance, that's probably not realistic for a lot of families.
Thanks very much. We're going to end with one final question to each panelist. It's helpful, I think, to leave the last thought of the day as a takeaway message from everyone at the table. So if there's one or two key ideas, concepts, or policy considerations for state lawmakers in the audience that they should have in their brains as they walk down the hall, I think that'd be a good way to end. I think we'll start with Donna and work our way backward through the order, and hopefully end with Dr. Wilensky, who I believe is still connected via audio to the meeting.
I guess I'll just go back to the questions that I tried to reinforce in my talk is how do we want to retain or continue working toward the governor's, the goal the governor set it for with his entitlement reforms when he set them out in 2013 to reduce the uninsured rate by half. I didn't mention that we have gotten to about 195,000 person reduction. The goal was to reduce by 225,000 people. So we're almost there, not quite. How do we not roll that back? We want to make sure that our whatever kinds of entitlement reforms we're designing and whatever kinds of high-risk pools we may be setting up or the like have sufficient affordability provisions built in to make sure that there is genuine access to affordable coverage and sufficient incentive for people to remain participating in the non-group insurance market.
So I think what I would boil a lot of this down to is that if we think about healthcare, it's obviously massively expensive. And that's true, across the board. All of our programs are expensive. If you look at employer-sponsored care, employers, those premiums for those plans that many of us have are $10,000 to $15,000 a year. So there's a massive cost to healthcare. And I think it's helpful maybe to separate our way of thinking about that into sort of two buckets. One bucket is, given that high cost of healthcare, there are questions about how we finance it and how much of that we share collectively versus having each individual responsible for their own financing. And so it's helpful to set those types of questions into one bucket. And then there are other questions about what versions of reforms can we put in place that help affect the level of that cost and the growth rate of that cost. And that's often sort of a bit of a separate discussion. We've heard today some tensions where I think sometimes we get confused on the different pieces. And I would say, for instance, on a topic like high deductible and health savings accounts that I was talking about, we know a fair amount about how these different things can be used as different levers for affecting the mix of who finances the high cost of healthcare and how much we're doing that collectively versus having it at the individual level. In terms of actually saving costs and affecting the level of that cost, we don't have a lot of really strong reason for optimism that we're doing that very effectively yet. And so a lot of our policy on thinking about that end could use a lot more work, and there's a lot to be done because it's a complicated system and we don't have clear answers on that yet.
Okay, thanks. So I'll approach this a little more directly of your question. So some takeaways. I would just remind folks where we were some years ago when the ACA was being debated and then implemented. We had all the same questions that Donna raised about what might happen now. We had that whole similar set of circumstances then. What's going to happen in the insurance market? How are they going to adjust so fast? What's going to happen to consumers? Who's going to educate them? Market's going to blow up. These exchanges aren't going to work. No, they're going to work. All those things were out there. And then remember how it was passed. So Dr. Wilensky mentioned Senator Scott Brown taking Senator Kennedy's seat after his passing. So remember, that changed the filibuster-proof issue. And all of a sudden, a bill that still needed work became law. So just remember and take a step back and look at the field and the forest as we look at all these things. So, but there are a number of flaws in the ACA that we have an opportunity to correct. As Dr. Wilensky mentioned, as I reiterated, we really haven't moved the needle on quality as much as we should have. We haven't significantly achieved payment reform. And those things, if we don't succeed at them, will still put us in a difficult place from a quality and cost perspective. So it's a double whammy if we don't resolve those issues, or at least make significant steps towards them. And then I would ask folks to consider these things three-dimensionally. And what I mean by that is they're talking about repealing the Affordable Care Act and Medicaid changes. Those likely intersect. If we are to prevent folks from falling through the cracks, as Governor Walker and Speaker Ryan and others have said, then we have to look at that three-dimensional model of how Medicaid and the insurance market, the commercial insurance market, work together to provide coverage for a growing population. So that seems obvious to some of us, but I think it's getting missed in some places when these are talked about in isolated ways. So they may be addressed in isolation from a legislative component, but they do work together regardless of how they are addressed in that formal atmosphere. So there are practical things on the ground that will need consideration. So think of that 3D chessboard.
Dr. Wilensky?
Yes, I have three takeaways. First, uncertainty and change is part of your future. I know that's difficult when you are trying to run a program or be a legislator, but that's a fact of life. Second is that you should anticipate substantially more flexibility when it comes to Medicaid, no matter what else happens. You will have an orientation in your CMS administrator toward greater flexibility, and also the HHS secretary and the administration in general. The unknown here, though, is how strict a line OMB is going to take with regard to whether or not your waiver request produces budget neutrality over at least a 2 to 3 year period, if not each and every year. I was a big proponent of giving states the option to do most of what they wanted to do, but I would frequently run into a recalcitrant OMB who was not convinced it was really budget neutral. So in general, you will face a much more receptive audience with regard to some of the requests, work requests, drug testing requests that you mentioned, but OMB's role is at this point unknown. And finally, and very importantly, you as a state need to decide where you are on this block grant issue. There will be some requirements, but I assume in response to some of the questions that were raised during the various presentations that most of the regulatory requirements we now see in Medicaid will get waived with a block grant. That's the idea. But again, it's very important that, in my view, that you insist on a per capita block grant so you're not held hostage to economic swings that you can't control. However you decide on the block grants, be sure that Speaker Ryan and others that are part of your delegation know where you stand. I believe that your position as a state will be very important in what happens next.
Thank you very much, Doctor. Sam, you want to bring it home?
And that'll bring today's briefing to a close. I want to let everyone here in the room and watching online know that all slides are already posted on our website at www.evidencebasedhealthpolicy.org. So all the PowerPoints and the resources are online on our website. So feel free to check those out. For those of you in the room, before you leave, please be sure to fill out the pink evaluation form and leave it either with one of our staff members or on the table where you registered. Again, that's very important information for us. And finally, thanks to all our panelists here in the room, to Dr. Wilensky via video, to Representative Sanfelippo for moderating, and to our attendees today. This discussion adds to the ongoing dialogue between the campus and the Capitol, and we can't do it without all of your support. So thank you and have a great day.